My name is Niels Peek. I'm Professor of Health Informatics at the University of Manchester. I'm also the strategic lead for the Health and Medical Sciences program from the Turing in Manchester. And I'm going to give a short non-technical talk. I'm basically going to argue why we need causal prognostic reasoning in medicine. And why we need that very badly. So, as some of you may know, prognosis and prognostic methods, clinical prediction methods, is a very lively field of research, part of epidemiology and medical statistics, and increasingly also machine learning, and a number of people who contributed to this fortnight work in this area, including myself and Matt, but also Roman and others. And on the slide here, I've just shown two books, which I think are both very good books in the area. One's a classic from Ewout Steyerberg from the Netherlands, and the other one is an edited volume that appeared just about a year ago. And I could recommend both books if you're interested in this area and want to know more about what are the methods and standards available in this field. So why do we need prognostic models at all? Well, the main reason in medicine is that prevention is more effective than cure. And I've illustrated that on the slide here with cardiovascular disease, or more specifically atherosclerosis. So as you probably know, this is a disease that slowly develops over time and for a long time will actually be asymptomatic. So you will have it, but you will not notice it, and it will not be something that is measurable or provide symptoms. Only after a number of years, the first symptoms might appear, which could be, for instance, shortness of breath or accelerated heart rate. And then even further down the road, there may be chest pain, and people start experiencing more serious events like heart attacks. So this takes a long time. And once we're at that final stage, obviously we're too late, because by that time, it's no longer possible to reverse the disease. There's still treatments, but a lot of the damage to the arteries will already have happened. So it's much better to start early and basically prevent this whole process from happening. And this is not just true for cardiovascular disease, it's also true for many other diseases: cancer, diabetes, renal disease, many examples. Also many health, mental health problems are better to prevent, easier to prevent than to cure. So if we can predict who's at risk of developing this disease or any of the other diseases, then we can be very targeted in our prevention efforts. Obviously, there are also population-wide measures that are being taken to prevent these kinds of illnesses. So the general smoking ban is a very good example. But if we want to go further than that, we need to know who is it specifically who is at risk. And so we can provide targeted interventions, targeted treatments to prevent disease. So this is why we have prognostic models. Now, the message that I want to convey today is that existing prognostic models fail to properly support clinical decision-making around prevention because they do not support causal reasoning. So like Matt was already saying, existing methods to develop prediction models are purely associative and do not have this causal reasoning component. I think that certainly in medicine, but also in many other areas, we need this causal reasoning component. And this is what I'm going to try to make clear today in my talk. So let's go to an example right away. So this is Qrisk, which is a cardiovascular risk calculator, which is freely available on the internet. You can go to qrisk.org yourself. I would recommend to try that. It's quite nice. Tells you something about your future. So this is a tool that tells you what your risk is, your personal risk of getting a heart attack or a stroke, so both cardiovascular events, in the next 10 years. And it is based on routinely collected health records from primary and secondary care, the Qrisk, the Qresearch database. And that database goes back about 20 years. And it's all routinely collected data, and it was used to develop this risk calculator using a Weibull model, which is a specific type of statistical model using survival analysis. So what I've done here is entered the details, the risk factors for patient Joe, which you see on the top right-hand side of the screen. So Joe is 50, as you can see on the left-hand side. He's a male, he is white, and then I've provided a number of other types of information. So his smoking status, he's a heavy smoker, so that means 20 cigarettes a day or more. He's got type 2 diabetes. He doesn't have angina or has had a heart attack. He doesn't have chronic kidney disease, he doesn't have atrial fibrillation, but he is on blood pressure treatment. So he must have had high blood pressure, and therefore he's now being treated. I've left all the other things blank. Qrisk doesn't force you to provide all the information in the template, but I did provide body mass index information. So Joe's height is 178 and his weight is 95 kilograms. So with that, Qrisk comes back with a risk for Joe of having a heart attack or stroke within the next 10 years of 23.9%. So that is quite substantial, as you would have expected with Joe's lifestyle, age, and the diseases that he already has, like diabetes and high blood pressure, hypertension. Those are all very strong risk factors for heart disease. So it's not a surprise that he has this pretty massive risk of getting a heart attack or stroke within the next 10 years. So let me progress to the next slide. So this here's Brian, and Brian was one of the experts. Brian Macmillan is one of the experts that came to visit us during the fortnight. So he's an academic GP, and in his work as GP, he uses Qrisk quite a lot. And what he told us is that if he comes across a patient like patient Joe, one of the first things that he would do is, after computing Joe's risk, as we just saw, and discussing that with Joe, he would then change Joe's smoking status in the tool to ex-smoker and recalculate the risk. Now, in this case, what we get, hopefully, if it works, there it is. What we get is that now Qrisk says Joe's risk of having a heart attack or a stroke in the next 10 years is 14.6%. So that's substantially lower. It's almost 10% lower, 10% points lower than it was. So this way, Brian tries to convince Joe that it would be a good idea to smoke. At this point, I'd like to pull up the first poll. There we are. So my question for everyone in the audience is, so what does this number that we now saw in Qrisk, 14.6%, represent? Is it the patient's, so Joe's estimated risk of having a heart attack or stroke within the next 10 years if he would stop smoking now? Or is it his estimated risk of having a heart attack or stroke within the next 10 years if he had stopped smoking at some time in the past? So please go ahead and enter your vote for this poll, and I'll pause for a second. Okay, could you show us the results? Right, so 21% have said what this number represents is the risk of Joe having a heart attack or stroke in the next 10 years if he would stop now with smoking. All the other people have said, no, it is actually the risk if he had stopped smoking at some time in the past, and that is the correct answer. So what this does is change the prediction, Qrisk prediction, to the average risk of people who are ex-smokers, still having all the other characteristics of patient Joe. But the ex-smokers obviously are people who stopped smoking at some time in the past. And that could have been yesterday. It could also have been 10 years ago. So really, changing the smoking status to ex-smoker doesn't really answer the question that Brian and Joe have. The reason for that is very simple. It's that the question that they have is a causal reasoning question. We want to know what would happen if Joe were to stop smoking now. And that is a question that this tool and all the other prognostic models that we have, all the other prognostic tools that we have in medicine, fundamentally cannot answer, because they don't permit causal reasoning. What they permit is associative reasoning. And this is what the tool is doing. So let me progress. Apart from stopping with smoking, one of the other things that we can do is give people drugs if they have a high risk of cardiovascular disease like Joe. So in the case of Joe, I think every GP would certainly recommend to stop smoking, probably also to lose some weight, but probably they would also consider to prescribe statins. So in the UK, the NICE guidelines say that for every patient that has a higher risk than 10%, the GP should consider to prescribe statins. So statins are probably one of the most powerful drugs to prevent heart disease. Also one of the most widely prescribed. I think statins actually now are the most widely used drugs worldwide. What I've shown here on this slide is a diagram taken from a Nature paper from a couple of years back about precision medicine. And it shows for a number of drugs which are very routinely prescribed, not just statins, how many people we need to treat to save a single life. And for statins, so one of the most frequently used statins is Crestor, rosuvastatin. We need to treat 20 people in order to save one life. So that's quite a lot. So Jesse, could you bring up the second poll, please? So my question for you, if Qrisk says that someone's risk of having a heart attack or stroke in the next 10 years is high, say higher than 10%, like the guidelines say, should we treat them with statins? First possible answer is yes, always. Second is no, only if taking statins would actually reduce their risk of having a heart attack or a stroke. So a couple of people, 12% have said yes, we should treat them always. But the large majority, 88%, have said no, only if taking statins would actually reduce their risk of having a heart attack or stroke. And I would agree with that would make sense. The problem is that the tools that we have at the moment do not permit us to do that. So the only thing we can do is treat them always if their risk is higher than 10%. And that is also what the NICE guidelines say, what we should do. But obviously that leads to the situation that we see on the slide, that we treat 20 people and actually only in one of them that is going to make a real difference. So what I'm arguing is that we need tools to predict who would benefit from statin treatment, just like we need tools that show us what the benefit would be from stopping with smoking. And only if we have such tools, we can actually properly support the decisions that GPs and their patients have to make. So I'm going to move on to a second example, which is about preventing emergency hospital admissions. And again, just like cardiovascular disease, this is one of the most frequently studied areas in the prognostic modeling world. And the reason is that emergency hospital admissions are typically the kind of thing that you want to prevent from happening. and of which everyone feels that, you know, it should be possible in many cases. Obviously, it's not possible if you end up in a car accident and you have to be brought to the hospital for emergency treatment. But for medical conditions, we would very often be in a position where we can kind of foresee that that is going to happen. And if we then intervene accordingly, we can prevent that emergency hospital admission, which is a very good thing if we can prevent it, because these emergency admissions are very often highly disrupting and even traumatic for the people involved. Very often there are long-term consequences for the patients involved, and also they're associated with very high costs for the NHS. So there are multiple reasons to try to prevent them. So there's been many studies that developed prognostic models that would predict in individual patients whether they are at risk of such an emergency hospital admission. And an example is shown here. So this was a study around the PRISM model, so predictive risk stratification model. So this model was introduced in the GP's office, essentially, and it would inform them for patients that they would see what the risk was that that patient would be admitted to hospital as an emergency in the next, I think, month or 3 months or so. What they then did is trial this tool. So they conducted a randomized controlled trial where the tool, this prediction tool, was given to 50% of GPs, and another 50% of GPs didn't get the tool. And then they observed what happened to emergency hospital admissions, as well as other use of NHS services. What happened is that actually in the GP, in the general practices that could use the tool, more people ended up with emergency hospital admissions than in the other arm of the trial. So that was a negative result. And in fact, this is not the only time that we have found this. There's been a number of studies now that have shown that these risk prediction tools either have no effect at all, or even lead to worse outcomes. The question is, why is that? Why is this not helping? And I believe that just predicting the risk that someone would end up in hospital is simply not enough. We have to look at what we can do to prevent it, and specifically at the effectiveness of those interventions, and try to predict whether a specific intervention that we could undertake to keep people out of the hospital, whether they would actually help in that specific individual. So being able to do causal reasoning at the level of individuals, so causal predictive reasoning. And none of the tools that have been developed so far do that. The only thing they say is this patient will end up in hospital. I think probably in studies like these, that might even have led to some form of cynicism of the GPs involved, saying, well, if the tool says that, it's probably going to happen, I can't prevent it anyway. So what GPs need is a tool that tells them not which patients are at high risk just, but which patients are likely to benefit from preventative treatment. And that's causal prediction. So I'm going to move to my final example, which is around COVID-19. And also for COVID-19, currently there are many prediction models, prognostic models being developed. In fact, there was also already a review published a couple of weeks back in the British Medical Journal, which is see over here. And in that review, a number of different types of models was identified, but many models focus on expected duration of ventilation and also on mortality risk. And the idea here is that in a COVID-19 crisis, obviously we're now after the first peak, but in the future, as we all know, there might be a second wave and a third wave, etc. And then again, we might be in the situation where we are short of beds, ventilators, staff, etc. So that means that we will have to apply some form of triage. So the thinking behind these models is that if we can predict in individuals who is at high risk of dying, and who would probably stay very long at the ICU because they need ventilation for a long time, and who would stay shorter, we can use that to triage. So we can triage patients and, for instance, say, okay, those with a very high mortality risk, but probably a short length of ICU stay, we're going to give them priority over others because they need it the most and would not use too many resources, which seems a reasonable thing to do. Again, here, I think we're missing a trick, because what we need to do is try to predict who would benefit from ICU admission and from ventilation. It might be that the benefits are not so much in this group, but they could be distributed over all the 4 groups, or perhaps in one of the other 3 groups be more prevalent. So again, what we need is a tool that can predict what are the benefits at individual patient level. And again, that's a causal reasoning question. So just to conclude, clinicians need tools that can tell them whether a course of action is likely to benefit their patient. This requires causal reasoning about the consequences of actions at the level of individual patients. Existing prognostic tools focus exclusively on risk and therefore fail to properly support this type of clinical decision making. So thank you very much for listening.